guideline, we are giving them the clinical skills on-site, but also the mentorship skills, as well as the data management. And then we assign those mentors to support lower level health facilities. So we are using what is called hub and spoke. And this is very important, but you need to use people from the higher center with enough exposure and skills to support the lower level health facilities that we call them as a spoke. So this is very important, and also ensure the continuous communication between the mentee and the mentors, including forming the WhatsApp group so that they can get real problem-solving support. But also, very, very important, you need to look on, depending on the gap that you want to address. So we implement different models. For example, the gap is on anesthesia for obstetric or surgical skills. So then we use an intensive support or clinical attachment, working with the professional association to address those gaps. But so during this session, we use also OSCE, the objective clinical evaluation, to assess the change in skills. But very importantly, how can we link skills change with the improvement of the health facility using the quality of care indicator, for example, the PPH case fatality rate, resuscitation with bag and mask. But I want to highlight very important issues here that, yes, there is a skills being impacted to service provider, but how can we retain the skills? This is very, very critical. So the continuous practice is very important. And to make this happen, for us, we have been selecting those we call champion, who can ensure the peer continuous practice is implemented in the health facility. So just to wind up, yes, there are things need to be changed. For example, in terms of leadership as the health facility management, to ensure this continuous practice are happening to retain the skills, and also looking into to ensure that people are working in a certain unit for longer time to have an exposure. But also we see the opportunity currently having the professional association, but also use of virtual platform for skills. Thank you very much.
I think before you pass the mask, the mic, additional question. You have talked quite a lot. Now this is in 1 second. During your implementation, can you tell the audience what are the challenges that you have observed and possibly opportunities which are there for us to move towards the competence-based training? 1 second. You say just in a word.
Yeah, so for during implementation, so one of the challenge, and I think this need to be taken into consideration, is a leadership and accountability toward the implementation of high impact intervention, like here we are talking in terms of competence-based training. But yes, as I said earlier, the opportunity are there. We have the service provider, we have professional association, we have a technology to use also in terms of virtual mentorship and likes.
Okay, thank you very much, Dr. Masenga, for your answers. I'll now call upon Mama Freddy Mwanga from TAMA. We all understand that professional associations are key to ensuring safety of patients and the public at large in advising the government and training institutions. Now, can you tell us, now in 2 minutes, because we've consumed quite a lot by your friends, now within the concept of competence-based training, what is the role of professional association in making sure that we move towards competence-based so that we make our patients safer and the public as well?
Thank you, Professor. The role of professional associations was actually alluded by the last speaker. You mentioned professional associations several times. And I'm saying that the professional associations are key and central in competence-based education. Because what we do is we take on from where the pre-service left. We are noting, and the assessments are noting that most of the graduates from pre-service training come out with inadequate competencies. And the midwifery say they come out with inadequate competencies to save life. And the role of the professional associations is to ensure that we conduct capacity building to ensure that our members or service providers in the clinical area have adequate competencies to save life. We do conduct in-service training, and our in-service training is actually based on the need of the competence that is lacking for the individual or for the facility or for the group. We start by assessment, and then we address the gaps that exist in the terms of competencies. And competence-based training has been our main approach towards that. We do mentoring, we do supportive supervision, and collaborate with other professional associations, work very closely with the ministries of health and pure rights, and we've been getting support from various donors. For example, for TAMA, our main supporter has been UNFPA, who has helped us actually to be doing these capacity building activities. Where we've been, there have been reports of improved quality and actually reduced mortality for women and newborn. Thank you.
Thank you very much. Thank you. I know I've cut you short, but I think your message has been delivered to the audience. And now it's Dr. Fadhiluni. It's your turn now. I do understand about the EXACOG thing, and it has been allowed to run in this country. Now, we have been complaining of competency. Now, I would pose a question to you. With competence deficiencies that have been complained by everybody, of the discussants, now how are we going to ensure that graduates from the EXACOG will be competent in terms of knowledge, skills, and attitudes, so that they can deliver quality services and save lives and make us safer?
Thank you, Chair. Let me start by introducing what is EXACOGS, or EXA. EXA is East Central and Southern Africa College of Health Sciences. It has many arms, it has many associated colleges within it, and there is a College of Nursing and Midwifery, a College of Anesthesiology and Obstetric and Gynecology, that is within RAMNAC. So we have recently started the program in Tanzania and in other countries, 10 countries. So to answer your question is that how will we make sure that the competency is there and that the workforce coming from there is really able to take care of our needs? First, we have a very competency-based curriculum that has gone through a lot of revisions and inputs regarding to the needs and gaps that we have in RAMNA in the area, but also in the country. And this curriculum has been through the country of regulations and has been scrutinized to see if it fits the needs of Tanzanians. And then we have several efforts to make sure that all the trainers, because we are going to put it's a specialist training, and it's done as a fellowship training. It's a 4 years fellowship training done at a hospital which is equipped and capacitated in terms of having a specialist in it who is well trained as a trainer, who is well trained in giving competence-based training. And because there are going to be few people in a facility with very close supervisions, then we are sure that we are hoping that the outcome and the whole process of 4 years being mentored and practicing where the need is in the public facilities, the whole process will make whoever is enrolled in the program come out well competent, because it is a very one-to-one kind of training and very hands-on kind of training. It doesn't mean that there are no lectures, it doesn't mean that there are no theory-based knowledge points, but it is a very region-based, but also there are exams, there are checklists that you have to do this and this, everything that you're supposed to do. So it's a well-structured curriculum that is having several checkpoints to ensure that the trainee gets all the competencies that are required as highlighted in the curriculum.
Okay. Thank you very much, Dr. Fadhun. I know I cut short everybody so that I catch up with time, and I believe the committee will add me some minutes because we didn't start at 8. We started sometimes later, so I think I have some few minutes. Now we come to a big guy. I call him a big guy because he sits in the driver's seat, is where the policy thing is. Now, this question goes to Dr. Haruna, who comes from the Ministry of Health, Department of Training. Now, can you tell us, because you know there must be a political will, the policies must allow, and so if you say no, we cannot move. If we say yes, we move. If we say stop, we stop. Now, my question would be, from policy perspective, what do you consider to be the roadblocks? What do you consider to be the challenges? What do you consider to be opportunities when it comes to competence-based training? I know you want resource, and that resource is trained. You want to train them to become competent. Now, can you respond to that question? What do you see as roadblocks? What do you see as challenges? What do you see as opportunities as it comes to competence-based training? You're a big guy here, so you untie everything so that we move.
Thank you, Professor. Actually, the ministry is overseeing the education, especially for production of human resource for health. And in that aspect, we have various policies, framework, and guidelines that stipulate how to implement the education system in the country. And this education has been divided into two, pre-service and in-service. When we talk about the pre-service, we mean those from certificate, diploma, and so forth. And for in-service, we consider those professional development, including CPDs. So talking about the policies, we have this Human Resource for Health Production Plan, which stipulates how many human resources are needed and in what competences are needed to work in various health facilities. The second one, we have Human Resource for Health staffing level, which now stipulates at each facility how many people are supposed to work at that area and in what competences. So talking to that, we have this, now comes to Human Resource for Health Strategic Plan. Now this one is the bigger one, can tell how these people can be produced and in what competences and what are requirements to make sure that we produce a competent human resource who can work to improve healthcare service delivery. Then we have this, the bigger one now, HSSP, which lasted for 5 years, and we have HSP 5 now. Now can also stipulate who do we want and where to work. So talking to all this, our education system has been divided into two. There are those who have been guided by TCU, the universities, and we have these mid-level training programs which are guided by NACTIVATE, the mid-level training program. So the ministry also take a role on that. We have various examination guidelines, we have various curriculum, and we changed most of our curriculum from knowledge-based to competency-based in order to produce competent human resource for health. So there are a number of issues that we need to work on to ensure that we have these competent people. Not only the curriculum, but also teaching and learning environment. Human resource for health who are teaching there also are very important to ensure that we have this competence. Let's talk about the skills lab. Let's talk about the clinical areas. Those are the facts that need to be improved in order to produce competent human resource for health. Thank you.
Thank you very much, Doctor, for your elaboration. And if I heard you well and interpreted correctly, is that the ministry and the government at large kind of support the shift from the so-called knowledge-based to competence-based. Did I get it right? Am I right? That the government is supporting the competence-based training compared to the previous mode of training. So thank you very much, panelists, for your discussion. I know myself I have so many questions to ask, but I can't ask because there are so many people there. I think they have. I shall take a few questions. So if you appear to be the first, I will pick you first, and you direct the question to a person, not the entire panel. You mention this question goes to somebody. It doesn't go to the air. Can I have hands, please? And there's first hand there. And then there's another hand here. And then there's another hand there. 3 hands. That's enough. I think ask questions directed to a particular panelist unless you think your question needs a blend of answers.
Okay, I think
you better mention your name and your affiliations and then ask your question.
Okay, thank you, Mr. Chair, for good moderation. My name is Lusekelo Njonge. I work with Japago USAID Afya yangu RMCH. So my question goes to Professor Nyamtema. It's true that the quality of graduates that are graduating now is very low, and we have seen, and RMO and DMOs can attest here, sometimes they succumb to do clinical attachment in some higher facility in order to make this provider be competent. So my question to Dr. Nyamtema, what do we need to do to make our graduates that are graduating now competent enough so that the government does not succumb financial in terms of clinical attachment to ensure this provider are very competent? The second question to Dr. Nyamtema is, we know for higher cadre like MDs, dentals, they do internship. What can we do for these lower cadre to make them oriented in such an environment to make them competent? Maybe that's my question for now. Thank you.
Thank you very much. I think you don't have to give so much elaborations because we are, as I said, we are behind time. Professor Nyamtema, I think you have jotted down the questions. I saw another hand from this angle. Can we have the mic there, please? From here, and then there was a hand somewhere here. You know, there are just so many people. If you sit on that side, you don't see that there are many people. When you sit on the podium, you see a lot of people.
Thank you so much, Chairperson.
Yes.
And I congratulate everyone who is participating in the discussion. It's really awesome. So I got one question to ask from someone from the Ministry of Health, from the government. we are talking of practice, competence-based practice and training. But I wonder how the government is going to support the supply of equipment to our health professionals, because competence-based practice comes with good equipment and the tools we need to perform our job effectively. That is my question. Thank you.
Thank you very much. I saw a hand on the, now hands are increasing. I don't know who is helping me to monitor the auditorium. I'm kind of confused. There's so more hands than before. Yeah, I think it's you. You're welcome.
Thank you very much for this opportunity.
So,
My name is Ezekiel Mbao from Herbert Kairuki Memorial University. I'm so impressed with this discussion, but somehow I'm confused.
Don't be.
Because since the introduction of competence-based curriculum, the graduates that we are producing are less competent compared to those who were produced before the introduction of competence-based curriculum. Can you unpack this? And this goes straight to Professor Nyamtema. Thank you.
Professor Nyamtema, another question. You have so much questions directed to you. Now, the last one. Please, those who won't have an opportunity to ask questions, I don't know how we shall take care of that. Now there are so many hands. One more.
Hello?
Last hand.
Hello?
From a female participant. Yeah.
Nina mic here.
Wait a moment. Now we need a female participant. You know, we want to balance the gender here. So you mention your names and your affiliations and where do you direct your questions?
Okay, thank you very much, moderator, and also for considering gender balance. And congratulations to all panelists. My name is Dr. Mary Rose, and I work with Japaigo. But my question goes to all. I think one of the biggest challenges we have now is mushrooming of the private health training institutions. And probably very unfortunately, when competency-based training is concerned, they are not really using standardized practice, which is recommended by the Ministry of Health. So based on the experience of the panelists, I really wish they could recommend how do we support private health training institutions so that they can be able to implement competency-based training effectively. Thank you.
So who will answer that?
Specifically the ministry, but even others can recommend.
Even others.
Yeah.
Yeah, so thank you very much. I think we have taken 4 questions, if I'm not mistaken. And now somebody says he's confused and said he shouldn't be confused. You understand. You know, our maternal mortality has dropped, but competencies have also dropped. Now there comes the quagmire. What's happening here? Competence going down and maternal mortality coming down. We don't know what is happening. Now the discussants going to unpack that in the next 8 minutes. I think you understand why the guy was confused over there. So we start with Dr. Nyamtema and then we flow as we go. So Dr. Fazurun goes free. No question directed her. Okay, welcome, Dr.
Thank you. Yeah, the first question actually was about the attachment and the fact that more trained staff are tasked to pass through the internship training, but others are the rest, the certificate and the diploma holders can just go and work independently. But I just wanted to really congratulate the management that they have decided to introduce a program for the certificate and diploma holders who just graduated. I think that's a very good practice, and I think should be adopted by other places. This is very important. I recommend that we consider attachment or introduce a sort of internship for all who graduate. Before we allow them to practice independently somewhere, they should be attached to the facilities which are busy so that they get the competencies. And actually I would say this is part of the implementation of the curriculum as well. So it should be like that. So it's a good idea. It's a good innovation that you have done, and they should be taken actually by the authorities to make sure that nobody is recruited directly from school to work independently before internship program. This is my view. From karaoke, I think this is very interesting, and we have already responded to it. The competencies are dropping. Maybe we don't have really studies indicating maybe in the past, before we introduced the competence-based curriculum, we had very high competencies, but we have evidences that we have significant reports of incompetence deficits in our community. And for that matter, we need to review the design, as I said, the focus to the must know. But the implementation process of the curriculum, having a document around, that we have the documents for in the Ministry of Health and all those things, that is not enough. We need to review. Curricula should be reviewed, and this is a time, it's high time that we review and focus to the must know, what is needed by the community. Yeah, it's very surprising that mothers are dying and we are losing even the newborn because of competence deficit. I think that is not acceptable. So we need to redesign the curricula and have a focused, and the focus to must know, but also the implementation process. All the stakeholders should be involved. Thank you.
Thank you very much, Dr. Ntema. The second question, I think, was directed to someone from the Ministry of Health. Dr. Haruna, I think that was your question.
Yeah, thank you. Thank you all for your questions. However, the first question didn't specify where those equipment supposed to go, in health training institution or in facility. However, the government does both.
Okay.
Government, in collaboration with the various stakeholders and implementing partners, they provide this kind of equipment. That's why nowadays we have all the services at the health facilities to ensure that community are given the needed health care services. So I can tell that the government is providing any kind of support that is needed. And with regard to mushrooming of private health training institution, particularly mid-level, I think mid-level training programs. For the case of curriculum, for mid-level training program, we have a national curriculum that is guided by the NACTE standard and the ministry policies and guidelines. And actually, this is collaborative work together with the government, private partners, association, councils, and also any who is interested to ensure that the production of human resource for health who is going to provide quality health care services is considered. So it's a collaborative work. Thank you.
Okay, thank you very much for your answer. As far as my memory is concerned, I think all the questions have been responded to. You may not have been satisfied with the answers. You may see them maybe during break time and ask your question. We don't have time for that. But I think we should all acknowledge that the lives of these pregnant women and their newborns are in our hands. So when it comes to competence, it's our business. It's what we are. I would say is what we do for a living, and so we should be serious about it. And as Professor Pepe said, the topic is really wide and big. We couldn't unpack it in 1 hour, and everybody gets to understand. It needed much more time. So this is what you could be able to unpack. So thank you very much for your attentiveness, but I think I should thank Professor Pembe for your nice plenary presentation and discussion. Thank you very much for your discussion and response to the answers, the questions that were asked by the audience. As you leave your chairs, and as I leave the podium, Can the audience please clap for us, please? Thank you very much. Welcome, Dr. Bishanga, to proceed with the next session. I think I've used less time than allocated to me because we started 8:20, I've finished 9:20. That means 50 minutes. 50 minutes. Yeah, thank you very much.
Another round of applause to the panel, please. That was our first plenary, which was supposed to start at 8 o'clock. We didn't start at 8 o'clock, but we started around 12 past 8, which is not bad. We are 20 minutes behind, but I assure you we're going to be able to catch up before end of the day. So now we move into our second plenary, which is on the current status of maternal and neonatal mortality in Tanzania. What are the program and the policy implications towards the SDGs, which comes by 2030? This plenary was supposed to be chaired by Honorable Dr. Jakaya Mrisho Kikwete, the retired President of the United Republic of Tanzania, but we have a small change, which I'm going to announce now. Apologies for a slight delay. I was just saying that we are going into our second plenary of day 2, which is on the current status of maternal and neonatal mortality in Tanzania. We all understand that we had the recent news of a decline in maternal mortality, but stagnated neonatal mortality. And now this plenary will be able to discuss with us the implications, programmatic and the policy implications of the current status or situation as we strive towards, achieving the SDGs. Now, our chair for this session will be Dr. Angelo Nyamtema. I'll introduce Dr. Angelo as a consultant and a senior lecturer of obstetrics and gynecology at the Tanzania Training Center for International Health, TTCIH, and at St. Francis University of Health Sciences in Ifakala. Dr. Angelo worked as a medical director at St. Francis Referral Hospital, as well as a deputy director at TTCIH at some time back. Dr. Nyamtema has spearheaded and coordinated implementation of a range of maternal health projects in Tanzania. As you may remember, even during the keynote speak of the first plenary, his papers were referenced in a talk. So I also read a lot of his papers when I was doing my PhD, so he's a very well-known scholar. Nyamtema has also a very vast experience in clinical practice, training, and leadership. He has published several papers in the areas of safe motherhood and medical education. Naomba tumpigie makofi Dr. Nyamtema, karibu. Uweze kumtambulisha keynote speaker ambaye najua yuko hapa tayari. Meanwhile, if the keynote speaker will bring your laptop, so if you can have ICT person come here along. So you wait for the chair to introduce you. Thais, hello. The chair will introduce you. I'm sorry. Yeah, I'm sorry. So please. IT. Can I have someone from ICT, please?
Good morning, everybody. Once again, we have another plenary session, and for the same process. And before you, we have a well-experienced person to give us a keynote. It's like an introduction to our session. This is called Tis Boema. From University of Manitoba in Canada. I know personally this person, have been working with him when we were reviewing the health sector strategic plan. So he's very competent, and I hope that you will enjoy the session. So please, Tis, karibu sana.
Asante, hamjambo mabibi na mabwana. It's a real pleasure to be here. And I would like to thank the organizers for the invitation. It's actually, I was just thinking, it's since the first demographic and health survey in 1991 that I've been a regular collaborator with Tanzania Ministry of Health and the many good research institutions that you have. And while I was at WHO for 15 years, it really informed global guidance. I learned a lot from Tanzania. One of those things was that we, when I was at WHO, were the secretariat of a commission for information and accountability for women, children, and adolescent health. And when you say information and accountability, you mean science and politics. And it was a great honor at the time that the co-chairs of that commission was Prime Minister Harper from Canada and President Kikwete from Tanzania, who I think has really been a champion for RMNCH globally, and also in country. And I think also subsequent presidents have really made it a priority. I'm thinking about Big Results Now and other efforts. So, did it make any difference? So let's take a hard look at the data to see whether the trends in maternal mortality, stillbirth, and neonatal mortality are going in the right direction and are exceptional or not. So that's my first part, and then I will go into something which we call a maternal, stillbirth, and neonatal mortality transition. So we'll look at Tanzania's experience and compare it to the experience of 150 other countries in terms of fertility change, coverage, and inequalities, and quality of care. And then that will give us some reflections on what are really the priority strategic issues for further progress at the higher level. So let's start with the numbers. So before I go to mortality, I just want to say a few things about delivery coverage since 2010. And what the red line is showing is really an enormous increase in birth in health facilities in Tanzania, from around 50% to over 80% right now, according to the last demographic and health survey, of which you've just seen the results. That is an enormous increase. if we think that today there are about 2.3 million births in Tanzania overall, then almost 2 million of those take place in health facilities. If we go back to 2000, when there were far fewer births, it was only about 800,000. So it's more than 2 times more births in facilities. So there are more health workers, but they also got more work to do, so they're busy. So this enormous increase has been occurring in all groups, but its coverage is still about 60% in the poorest of Tanzania. Now, in parallel to that increase in coverage of birth in health facilities, which is a good proxy for skilled birth attendance, also the cesarean section rate has been increasing from just 2% in 2000 to 5% in 2010 to now 11% of deliveries. So 1 in 9 deliveries is a cesarean section in the whole population. Now, we always look at surveys, but I just want to show you the other dotted line that is there now. And that's the Mtuha DHIS2 data that show a trend for 2012 to 2022, actually, with the data that you all, or health workers, generate in health facilities. And that fits exactly on the surveys. That shows us that the health management information system in Tanzania is quite good, and one can monitor, perhaps even at the district level, what progress is. Okay, so now let's turn to mortality. Maternal mortality is really difficult to measure. We express it as maternal death per 100,000 live births, the MMR, or maternal mortality ratio. Now, if we look at the picture in Tanzania, it's complex, but it will show a downward trend. So let's see what data points there are. So first of all, there are the surveys. So this red line that I'm showing now shows the surveys, the last DHS, and now the new DHS comes out, and there's an enormous plunge in maternal mortality to 100. So much that many people say, this is impossible. So let's look at some of the other data. Well, the UN estimated Tanzania mortality around 238, maternal mortality. The last survey said 104. Then there is the census. The census also had questions, different questions about maternal death. And maternal mortality dropped from over 200, to almost 300, to 200, or just below, 194. So it's higher than the surveys, but it also shows a declining trend. There are other sources. Of course, we also have the reporting of maternal death in the health facilities. So this line shows, the red line shows you the reporting that is done in health facilities, and that's the institutional maternal mortality. So the mortality divided by the birth in the institutions. And that one is much lower. It's around 100 or even lower. We know there is quite some underreporting in that system, but then since about 2015-16, the ministry has been trying to improve that with the maternal death surveillance reporting system. And that's the yellow line there at the left bottom. And that shows also levels about 100. We think the reporting is more complete in that system, and it also shows a decline over time. There are, of course, many other studies that can give us data on maternal mortality in Tanzania. There are 2 that are particularly of interest, which are the health and demographic surveillance systems. Ifakara ran the Rufiji health and demographic surveillance systems, Rufiji and Ifakara, and had much higher mortality, but that was around 2010. And also in Magu, there is the NIMRI-supported health and demographic surveillance systems, of which the most recent maternal mortality is around 300. So the big picture, I think, is there is a decline. It's probably not as strong as the last DHS, but overall the news is positive. Now, let's look at stillbirth. Stillbirth, we see a slow decline in mortality. If we look at the surveys, we don't see much change. Stillbirth rate is about 18 per thousand, or 1.8% of birth die before birth. If we look at the health facility data, we see some line going up and down a bit, but we see quite some decline. And we wonder, is that true or not? Or is it that it's actually underreporting? I think there is definitely some evidence of underreporting of macerated stillbirth. Fresh stillbirth are about 41% of all stillbirth in the DHIS2, but there's certainly scope for improvement. And then the last line shows the UN estimates, which is about 42,000 stillbirth in 2021 in Tanzania. But overall, we can say there is some evidence of a decline in stillbirth rate, but it's somewhere perhaps between the survey and the facility data. The next one is neonatal mortality. So neonatal mortality is primarily measured through the surveys. The UN estimates that are about 50,000 neonatal deaths in Tanzania. And so if we look at the national trend, we see some good decline from about 33, 34 in around 2000 to 2010 when it's around 25. But then something happens. It stagnates. It's still 24, 25. 24 in the last survey. So 24 neonatal deaths per 1,000 live birth. That's 2.5%. So that's not low. The SDG target is 12 per 1,000. So there's still a long way to go, and the trend is not very positive. It's flat. So the main causes are prematurity, and I think tomorrow is a special day for that. Intrapartum causes like birth asphyxia and trauma, and then also lower respiratory infections. But now, something really strange, and you probably have the explanation, but we have been struggling a lot with this. Neonatal mortality in Tanzania is higher in the urban areas than in the rural areas, and not just by a little bit, and it's not just one measurement. It's actually much higher, and it's been like that for the past 20 years. Neonatal mortality is around 35 in urban Tanzania, and we've also looked at Dar es Salaam a lot, and it's the same. Rural is around 20. That's turning things around. In most countries it's the other way around, although it's also beginning to see that the urban advantage is sort of starting to disappear. But why is in, for instance, Dar es Salaam, where more than 90% of the babies are delivered in health facilities, neonatal mortality so high? I'm sure you have the answer. We don't, actually. We've really looked at it in many ways. But okay, so that was the first part on the mortality statistics, and I hope I didn't bore you too much with those, because there are going to be some more statistics. So now I would like to put Tanzania in the context of a mortality transition model for maternal, stillbirth, and neonatal mortality combined that we developed based on data from 150 countries and experience over the past 20 years. And look at that changes in causes of death, fertility, coverage, inequalities, and health systems as mortality goes down. So what you see here at the bottom is stillbirth and neonatal mortality combined, and what you see vertically is the maternal mortality. So if you go to the left top of the graph, that's where mortality is really high. Maternal mortality is over 700, and the stillbirth is over 40, and neonatal mortality is over 40. So that's the highest mortality, phase 1. And then it goes down all the way to the right bottom corner, where both are low. All preventable deaths are dealt with. And so that's the phase 5. Now the star is the SDG targets. So if we combine stillbirth, which is the ENAP target of 12 per thousand, and neonatal death, with some idea of the maternal mortality targets that also Tanzania has, that's in phase 4. So also if we go look at the top, it really goes to getting better access of care, to more universal access to quality care. So let's see where Tanzania is. So on the right, you see the year 2000, and all those dots are the 150 countries with their stillbirth, their neonatal mortality, and maternal mortality combined, and the big red dot is Tanzania. So Tanzania is quite high on maternal mortality and starting to decrease on perinatal or stillbirth and neonatal mortality. It's the red dot, but you can see it's really on the higher side. Now 20 years later, all the countries have moved, but Tanzania is one of 6 countries that moved 2 phases, from phase 1, the high mortality phase, to the middle phase, on the way to the SDGs. So that is really a remarkable progress with the decline in maternal mortality, but also in stillbirth and to a lesser extent, neonatal mortality. So 3 reflections on this framework, and unfortunately we now turn it around. So the phases are from right to left. So phase 1 is high mortality, phase 5 is low mortality. And those little boxes are the typical patterns of countries when they move across phases. So when mortality is high, fertility is also high, usually around 6 children per woman. And when you have phase 4, where the SDGs are, or later, only 2 children per woman. So the red line is what Tanzania has been doing in terms of fertility, declining from 5.7 in 2000 to 4.8 in 2021. And they're in phase 3, the middle phase, and it's above the box. So that means that Tanzania has an exceptionally high fertility for a country that has reached phase 3. But to get further, the fertility typical for phase 4 is around 2.5. There are a few countries that have 3 to 3.5, but no country has reached phase 4 with a fertility of 4.8. So integrated debate of family planning, it may be a good thing to do. Second reflection, large inequalities in coverage are typical for the current phase of the transition, in phase 1, 2, 3, but it needs a major reduction to be able to advance. So what we see here, those boxes, are the typical gap between the poorest and the richest. So the gap between the coverage and institutional birth between the poorest and the richest is 60% or so, or 50% in the first 3 phases, and then it almost disappears in phase 4. Tanzania has been successful in reducing the gap in birth coverage from over 50% to 33%. That's the red line. So that it's going well, but now the big jump is needed to reduce to get to phase 4. So inequalities should be a priority. And I just take the example of cesarean sections. The poorest 20% women in Tanzania have a cesarean section rate of 4%. So 4% of their birth are a cesarean section. That is lower than WHO will recommend, which would be around 10% or so. 10% is the need. If we think about the richest women, it's 25%. Now that is too high. There's also quite a lot of overuse of cesarean section when one is more wealthy. So there's a gap to be reduced. The last point, quality of care and type of health facility. The major increase in coverage of birth by health facilities has, in Tanzania, as in many other countries, has been in smaller facilities, dispensaries, and according to the DHIS2, about 1/3 of deliveries occur in health facilities, and health centers, 24% of those, and only 24% take place in hospitals. If we look at the transition in countries in phase 4, 73% of those have their birth in hospitals. And that doesn't mean that that is the only way to go, and I know there's a big effort of upgrading health centers, of which 25% have now the capacity to do comprehensive emergency obstetric and newborn care, but it does mean that there is a need to discuss the role of hospitals much more prominently now than in the past, when access, getting women into the facilities, was the key, and that the quality of care in those facilities is absolutely critical to save lives from, for instance, the small and sick newborn, to be able to bring down neonatal mortality. So, in conclusion, Tanzania has had a major increase in coverage of interventions, with good evidence of reductions in maternal mortality, stillbirth rates, and to a lesser extent, particularly in recent years, neonatal mortality. The facility data, the DHIS2, and before that the Mtuha, in Tanzania are really an important source of data, and much more can be done with those. They're an important, reliable source in the hands of the Ministry of Health, and one can do council or regional or all sorts of trends with those data. So more use of those data is definitely good. The MDSR is, of course, an essential instrument. The maternal death surveillance and response system is a really essential instrument for monitoring and action, and a good integration with DHIS2 is important. Now, based on the transition model and this analysis, 4 main points. One is on urban. The poor neonatal survival in Tanzania, in urban Tanzania, needs to be addressed. Now, about 1/3 of the population is urban, and it's growing, so that is so important in trying to bring down mortality and improve survival. Second, an integrated family planning, maternal newborn health approach is needed, because the role of fertility and family planning in further reductions of mortality is important. Third, equity, strong targeting of the most disadvantaged groups to reach universal coverage, and I think particularly of the poorest, but one can also think about left behind districts, on certain other kinds of populations is essential. And lastly, the quality of care. And I think you'll discuss a lot of that also tomorrow in the context of the small and sick newborn, but a greater focus on access to emergency care facilities, access to hospitals for maternal and newborn care, including sort of newborn intensive care units for districts and so on, will be a very essential part of the discussion looking forward. So, Asante Sana, I think this work has been ongoing as part of the Tanzania Countdown collaboration on RMNCH and nutrition, where we try to support the Ministry of Health with good analysis and better data on RMNCH. It's led by Ifakara Health Institute, and I'm glad to see Dr. Masanja here, and a collaboration of the many good institutions and people that Tanzania has in science to support this effort. So thank you very much.
I can just introduce you. Yeah, so this was Thai's poem, and I did not have time to introduce him to you, but just briefly, this is a professor and a Canada research chair for population and global health. at the Institute of Global Public Health, University of Manitoba, Canada. He has leading the countdown to 2030 for women's and children's and adolescents' health from 2017, and was a director of health statistics at the World Health Organization for more than a decade. And he has published more than 200 articles in scientific journals. He has been involved in work with Tanzania. As I said before, he has been really supporting the development of the health sector strategic plan for this country since the early 90s. So he has vast experience. He has been trained as a medical doctor with a PhD in medical demography from the University of Amsterdam in the Netherlands. So once again, a round of clap. Yeah, you can see that he has addressed the current status of maternal and neonatal mortality in Tanzania. What are the program and the policy implication towards the SDGs? His work has been very nice and highlighted key points. I think it's a good foundation for this discussion. Now, it's a time for plenary discussion. There we have panelists whom I would like to call them. And the first actually is Kerry Nosa. I'm not sure if I pronounced him properly, but I just want to go through. I will tell you who he is. Very briefly. He's actually the High Commissioner of Canada in Tanzania. So it's a very good opportunity to be with him. Highly honored to call you to the front seat as the first person, and I will just tell you who he is. He has a bachelor in journalism at Carleton University, graduated in 1994 and joined the Canadian Heritage in 1994. He has served in a variety of functions, including managing communications for sports and for international and intergovernmental affairs. He has managed the government of Canada communications in the lead up to the 2010 Olympic and Paralympic Winter Games in Vancouver, Canada. In 2006, he joined International Trade Canada, and from 2007 to 2012, he served as a director of communication. He served as a director of communication services division, where he led the marketing program for the Canadian Trade Commissioner services. From 2014 to 2017, he served also as a director of aerospace, automotive, defense, and information and communication technologies in the trade section bureau. Overseas, he served as Canadian first consul and a senior trade commissioner in Bengaluru from 2012 to 2014, and as a consul general in the Hu city from 2017 to 2020. Most recent, he served as the acting Director General of the Trade Sectors Bureau. And here we have Kerry Nunes. Sorry, I previously pronounced your name incorrectly. Sorry for that. Please, your chair. So this would be this one of the panelists. And the second panelist will be Dr. Makwani, whom you already know is a senior medical doctor and currently heading the Department of Reproductive Health is the Minister of Health. Briefly, is a director of the Department of Reproductive Health, Maternal and Child Health from the Minister of Health in the United Republic of Tanzania. By profession, he's an obstetrician and a gynecologist, graduated from Muhimbili University Health and Allied Sciences, MOHAS. During his service, he has served as both a clinician, a researcher, and a teacher. He has worked setting up emergency obstetric and neonatal care and the blood services in both Tanzania and abroad. Some of the countries that he has used his technical assistance include Sierra Leone, Zimbabwe, Kenya, Botswana, Nigeria, and Afghanistan. So he has been in different places. Serving as a consultant, Dr. Makwani was taught in studying in a Liverpool School of Tropical Medicine, mainly on areas related to maternal and newborn care. Similarly, he has published a number of papers in the field of emergency obstetric and neonatal care and blood safety. Leading as a director at the Ministry of Health, Dr. Makwani pioneered independent, in-depth work on the use of routine data, especially those related to maternal and newborn care, that has resulted to a better understanding of root causes of death, hence leading to an influence on a policy change, which is more applicable to the local context. I hope we will get deep insight on what you are going to discuss this morning. Dr. Makwani, please. A round of clap. The third one is Sylvia Meku from NBS. Is a manager of social and demographic statistics, coordinated the DHS since 1999. She has a master's in survey methodology from the University of Maryland in the US, and graduated also from University of Dar es Salaam. Yeah, she's a professional trained sample size sampler. Sylvia, please take a seat, front seat. And then we have another person who will be one of the panelists, is Kim Jasper Mturi. He's a professor of demography and is currently a director of postgraduate research, innovation, and entrepreneurship at the University of Dar es Salaam College. Professor Mturi has been lecturing at the various universities. Is coming from the Tumaini University, actually, and has been lecturing at various universities in Tanzania, South Africa, Lesotho, and the UK. He has vast research and consultancy experience. In 2016, he assessed the implementation of SDGs in South Africa and published a paper from that assessment, and published in the Southern Africa Journal of Demography. Among the demographic research he has been doing include investigating the partners and the patterns, levels, and the determinants of childhood mortality and fertility. For example, in 1995, he co-authored an article that appeared in the journal, Health Policy and Planning, with the title of The Determinant of Infant and Child Mortality in Tanzania. More recently, he co-edited 459-page book entitled Explaining Fertility Differences in Sub-Saharan Africa, published in the Edwin Merrin Press. Among the many consultancies he has conducted include being a national consultant to assist the Office of the Chief Government Statistician, the OCGS, in implementing the action plan to address the baseline data gaps for SDGs monitoring in Zanzibar. That was financed by the UNDP, and the development of national population health and environment. So we have Professor Mture, and I would like you to know him. Please come forward and take your seat. The last panelist is Dr. Teopista Jacobo. He's a pediatrician. I think most of you know her. She's a highly experienced pediatrician with a strong dedication to improving the healthcare and welfare of children. With over 15 years of expertise in the child health service delivery and more than 17 years in public health, Dr. Teopista has made significant contributions to the field. Currently serving as the Chief of Party for the Comprehensive Child-Centered Care and the Services Project at the Christian Social Services Commission. Provides leadership and guidance in delivering vital technical assistance to the Ministry of Health and the regional implementing partners. The primary objective of the project is to enhance access to high-quality comprehensive services for pregnant and breastfeeding women, children exposed to HIV, and children and adolescents living with HIV. Furthermore, Dr. Teopista holds a position of Vice President of the Pediatric Association of Tanzania, where she plays a pivotal role in providing valuable technical assistance to ministries and other stakeholders. Her focus is on improving the quality of care for children, ensuring their well-being across the nation. Dr. Teopista is deeply committed to making a lasting impact on child health delivery while actively fostering collaboration among various stakeholders to improve the overall health and the welfare of children and adolescents in Tanzania. Dr. Teopista. So we have 5 panelists, and we have already, ties has already opened with the keynote speech, but then you need to add value. We start with the Professor Kim Turi. What is the global trend, and what is the status? And the status of maternal and the national mortality towards SDG. Can you share with us the global trend and the status of maternal and the newborn mortality towards SDG? You are given only 3 minutes. Please. Somebody with the mic? I think there is a mic somewhere. Okay, he has just a few slides to share with you. I think it's also allowed. Okay, please.
Good morning, and thank you, Chair, for that introduction. I have a few slides which I'll go through them quickly. My presentation is supposed to be very short, so please bear with me. I'll talk about the global trend of maternal mortality and how it relates to SDGs. Then I'll talk about global trend of neonatal mortality and how it relates to SDGs. And then I'll conclude. This is the first table I have. And it divides the world into different regions. I borrow this information from WHO with the other UN agencies. The only point I want to mention here is that there is a lot of variations. When we talk about a global maternal mortality ratio, there are a lot of variations, and sub-Saharan Africa leads in terms of highest maternal mortality rates, and of course we can see it compares from 800, 545 to some countries with 804. I presented the same information using a map. This is maternal mortality ratio in 2000. It comes from the same source. The colors show that maternal mortality ratios are very high, and as you can see, outside sub-Saharan Africa is only Afghanistan there. And in 2020, it changed a bit, but still there is a concentration of high maternal mortality ratio in sub-Saharan Africa. Then I took the global average, which started from 339 in 2000, declined to 2023 in 2020, and there, according to SDG, is supposed to be 70. That's our target for 2030. Now, following that line, you can see it diverges. If we extend the line as it is, it will go, that means if our effort don't change, it will go to about 160 something. So there is a region there of the two curves from where they diverge into 2020 to 2030. That means we need to improve our implementation efforts if the targets need to be realized. Then we move to neonatal mortality. This is the global picture, and I picked this information from UN agencies. There is a publication of 2019 in the Lancet, and they also grouped the world into different regions. The picture is not very different. You can see sub-Saharan Africa, neonatal mortality is quite high. It only declined from around 46 in 1990 to 41 in 2000 and to 27 in 2017. Overall, we see the world had neonatal mortality of 37 in 1990. It changed to 31 in 2000 and then 18 in 2017. Prolonging that line to 2030, it means the SDG of 12 neonatal deaths per 1,000 live births is more likely to be realized. I have a number of points to conclude. One, I have already said that maternal mortality rate is unlikely to meet the global SDG target unless we change the implementation strategy, especially for MMR for high mortality countries, and most of them in sub-Saharan Africa. The second is that neonatal mortality rate is very likely to meet SDGs target if the world continues with the implemented strategy underway. But when we are talking about general, about overall neonatal mortality, that's an average. There are still countries with very high neonatal mortality, the country with very low. So we need to be cautious with this type of conclusion. But also the final point is that as neonatal mortality becomes low, the reduction becomes more difficult. So we don't need, therefore, to relax because the target is around the corner. Thank you very much.
Thank you. Thank you. Thank you, Professor, for a discussion, very good, and it's giving us a picture of the trend and the status of maternal and newborn health in Tanzania, maternal and newborn mortality in the world. The second panelist is Sylvia Meko, and I just have a short question. I would like you to respond to this question for 2-3 minutes. The question is, what have we learned from the past Tanzania Demographic and Health Survey on maternal and newborn mortality in Tanzania?
Thank you, Chair. As you all are aware in this conference, everyone who is standing at the podium is speaking about maternal mortality, neonatal mortality, and the under 5 mortality. It's really good that at least most people have already picked up the results from the Demographic and Health Survey. I'm very honored today also to meet Professor Boema. He doesn't remember me, but I remember in 1991, on my first appointment, you were in Tanzania training people on how to do the demographic. Thank you, Professor Boema. Then what I can say from the data is that the statistics tells us that 5 years before 2022, more than 400,000 children under 5 died before celebrating their 5th birthday. And most of these children, more than two-thirds of these kids died in the rural area. And also 56 of these kids were neonates. But when you unpack the data, you find that most of the deaths occurred to teenagers and to mothers who are 40 years and above. And also the death occurred when the birth spacing was less than 2 years. And when you look at the wealth, the highest wealth quintiles are the ones which have more proportions of the neonatal death. And overall, the maternal mortality has gone down, as Professor Boema told us this morning. But again, when you look at the death, they are related to age and the children spacing. Thank you.
Thank you very much for elaborative discussion. And now the question is to Dr. Makwani. What is the status and the trend of maternal mortality, newborn mortality in Tanzania, and what do you think is the policy implications?
Good morning, everyone. Thank you for that question. As a minister, I would say we have been tracking the maternal mortality and the neonatal mortality in Tanzania. We have been tracking both using the routine data, but also using the survey data as well. But I'll focus much more on use of the routine data. Because this data, for us, it has been very helpful in terms of knowing exactly where maternal mortality occurs, what are the main causes of maternal mortality, and we can actually see when we do some analysis, we can get those drivers that lead to maternal mortality, drivers that do not speak our clinical language, rather more on system issues. So for us, it has been very, very helpful. Even for the case of neonatal mortality, we have not done very well in terms of tracking maternal mortality, neonatal mortality. And I would attribute that to our culture, for example, saying that if we have those stillbirths, most of them, they may end up unreported. So we don't trust very much about the data as we get in stillbirth and neonatal mortalities for that reason. However, because we are getting, these are pooled data, they again give us a lot of information in terms of knowing exactly drivers which lead to neonatal mortality. If I start with the maternal mortality, from 2016 we have been tracking the maternal mortality using the routine data. And initially we were tracking using DHIS2, there was DHIS2, there was a system which is using to track the emergency diseases. And then also we were using the MPDR system using our fellows from regions and districts. What we found was the number we get from the DHIS2, there were almost 1/3 of those numbers which we get from the routine data which we collect along using the Waratibu, these DRCHCO and the Regional Reproductive and Child Health Coordinators. So we reached a consensus that we must galvanize on using one system, especially looking into governance issues. If 3 data sets do not speak the same language, you have a lot of questions. And we galvanize in that area. So it has informed us a lot. And fortunately, in 2020, we released the one paper which was telling us that the maternal mortality, the probable maternal mortality in this country is around 100. And we just said that we think if DHS would measure it, it will be, the numbers will be between 1,500 to 2,500. We ended there and we forgot the paper. It was published, the paper was forgotten. When it came to the release of DHS data, I think the data shocked everyone, and including my professor there, shocked everyone. And you know, all of a sudden you get from 556 or 5530, and then it goes boom down to 100. You get a shock, and you can't explain that trend. So we had to correlate all these data sources to see if it may have reflected. And Professor Tees tried so much to talk about that area, so I don't want to repeat it. But what I would say is currently, the way we see the reduction of maternal mortality, we needed to change the strategies. Because previous strategy was addressing inequality, inadequacy in service delivery. There was no service which is being delivered in our communities. Currently, the surveys say that 75% to 85% of the population live 5 kilometers from the nearby health facilities. So that area somehow, that dynamics has completely changed. But what does the MPDSR data tells us? When you do critical analysis, and fortunately most of you have participated in those critical analysis, we did the analysis when we have reviewed 100 maternal deaths in 2022. We did the analysis when we have reviewed 300 maternal deaths in 2022. We did the analysis when we have reviewed 500 maternal deaths in 2022. The findings were the same. The underlying cause of maternal mortality are driven by issues of competence, that's number one, which stands between 80 to 85%. Second is an issue which is called practice and attitude. In Swahili, you will call it kufanya kazi kwa mazoea. We have been doing this all the way. What are you telling us? People do not want to ask for any support when they are stuck when managing the patient. So that one was contributing between 70 to 75%. And then the third area was an issue related on governance, leadership, and accountability. There's a big question in terms of how we account services, how do we follow up the way women receive antenatal care, and so forth. So to summarize, currently we are not, if we want to get our targets for SDG 2030, it is not the time whereby we need to talk about availability of services. It is the time now we need to talk about quality of the services we provide. And this is backed by the evidence we get from the routine data. When we come to neonatal care, yes, thank you. When we come to neonatal care, the review tells us that, evidence tells us that 1 out of 5 newborns who are born would need some extended care after birth. The evidence tells us that prematurity, asphyxia, and sepsis contributes to 80% of all neonatal deaths. So we did very well with helping baby to breathe, and we saw the data from TIS that it helped to reduce. And then we stagnated. We stagnated from 26, 25, 24, which statistical says there is no statistical difference. If we want to get a statistical difference, whereby the data, I usually joke with my people, the roof falls down, boom, we need to ensure that 80% of our hospitals have neonatal care to manage those children. I don't want to repeat the data which were spoken by Honorable Umi yesterday. It has shown that where you have put neonatal care units, in 6 months, 50% of neonatal deaths get reduced. So that is an area whereby we want to invest. I submit.
Okay, thank you very much, Dr. Makwan, and I think we have made our job easier to Theopista. Now, 1 minute, please.
Thank you, Chairperson. I think 1 minute will not be enough to talk about the neonatal death. So thank you so much for this opportunity, but I'll try my best to be quick, and I will continue where my teacher, Dr. Makwan, ended. So I just want to unpack a bit on the 24 neonatal deaths per 1,000 live births. I think if you don't put a human being behind the numbers, you are not going to see the burden of the neonatal death in the health system, even in the community. So as Professor Tai said, in the country we have an average of 2 million new babies each year. So with neonatal mortality rate of 24 per 1,000 live births, this will equal to 48,000 babies dying each year, and this will equal to 4,000 babies dying each month, and this will equal to 143 babies dying every day. This means that, naomba niongee kwa Kiswahili, kama una mayutong matatu yenye watu 48 full seat yakagongana pale Chalinze kila siku na kuua watu wote, this will equal to the 143 babies that are dying every day. What are we doing with these 3 yutongs that are killing, crushing newborns? What are we doing with that? So looking at that, you can even see, like, you get goosebumps when you realize that these numbers are human beings. These numbers are human beings and not like stones or anything else. So from that perspective, I would like to say that we have good policies, we have good strategies that we have been implementing, but what the numbers are telling us with the trend is that the interventions, the strategies have not been good enough to significantly address the newborn death. So we need to think different, we need to act different, we need to invest differently, knowing that 2/3 of all the neonatal death occurs in the first week of life. What are we doing to make sure that the newborn are surviving beyond 7 days, they are surviving beyond 28 days? And my last point will be that I would like to call upon the ministry, the government, and everyone, tuje na mpango mkakati wa kuokoa watoto wachanga. As much as we are looking at the mother or the woman, see it as a pregnant, we need to see that person in the womb. Yani tuanze kusema huyu ni mtu. The moment we are saving a pregnant woman in labor or during antenatal, let's think, what are we going to do to make sure that this baby survive and become an adult to bear another child, to have the population continue? Thank you so much.
Yeah, thank you very much. I think we'll come back to you also you suggest some interventions and all those things, and then please think about the kind of intervention, then you respond to some of the questions later. Lastly is the High Commissioner. Please talk about the development partners, reflections on the current status and the trends on maternal and neonatal mortality in Tanzania. Very briefly, 3 minutes.
Bonjour.
Bonjour.
Good morning. Habari za asubuhi. So interesting to bring on somebody with an international sport background to talk at this conference. It makes me, when I think about the other presenters and talking about the challenge ahead of us, I can't think of this in any other analogy but a marathon. And no matter how well you've done in a marathon, whether you're at the halfway mark, no matter how quickly you've gone, if you've made a personal best, there's still a long road ahead of you. But there is a finish line. And so I think just first off, Canada is proud to be, if you think about the work we do globally, we've been working for quite a long time on these issues. And thinking about this panel and thinking about who we've been collaborating with over the years, Tanzania keeps coming up. So in 2010, Canada's former Prime Minister, the Honorable Stephen Harper, and the former president of Tanzania, His Excellency Kikwete, co-chaired the titles of these conferences are so long. Commission on Information and Accountability for Women and Children's Health. And together there, we were working on improving global reporting, oversight and accountability on women's and children's health. In 2015, Canada was a founding donor to the Global Financing Facility for Women, Children and Adolescents, along with Norway and the Gates Foundation. And Canada is currently the largest donor to this fund, having contributed Canadian $630 million since 2015. In 2019, at the Women Deliver Conference, our current Prime Minister, the Honorable Justin Trudeau, committed to providing $1.4 billion annually for health, including $700 million for SRHR. And this will be maintained until 2030. In 2021, His Excellency Kikwete, again, working with our former Governor General of Canada, co-chaired a commission for Nairobi Summit on the International Conference on Population and Development 25. And here this comes back to my marathon analogy. They were focusing on ensuring that commitments to women and women's health and rights stayed on track. Here in Tanzania, as I wrap up, I just wanted to first say a very strong congratulations to the government of Tanzania for implementing universal health insurance. This is wonderful, and I think having access to health care is going to be a very important game changer to women and children and boys and men in Tanzania. Canada has been long an advocate for gender equality, improving access to and equality in the health system, and providing access to being able to stay in school, access to SRHR services, and this is something that's core to our feminist international assistance policy, and it really is something that drives Canada. We are very proud of being one of the most important contributors to the Health Basket Fund, and indeed we are the largest bilateral contributor to that fund, and we know that is important to ensuring health services to women and girls in Tanzania. Proud as well to be working with partners such as World Vision, Plan International, and Nutrition International, who are supporting women and girls to access a full range of sexual and reproductive health services. We also work with multilateral partners, and there's quite a few of them. We've been working with UNICEF, UNFPA Supplies, the Global Fund to Fight AIDS, Tuberculosis, and Malaria, UNAIDS, and the Global Financing Facility for Women, Children, and Adolescents. And so maybe just to end, as we approach, we're still a little distance from the final mile of this marathon, and as my colleague was mentioning, we really have to think about who we are here to help. And there's been great progress, yes, but any deaths are still deaths too many. Better is possible. And we really are working for the future of Tanzania. These young girls today, these little babies, they are going to be your next president, your next astronaut, the leaders of your businesses and your NGOs. They're the future. Asante sana.
Thank you very much. Yeah, actually we recognize your contribution actually to the area of maternal and newborn health in Tanzania. We have seen significant contribution, actually, the effort they were supporting our country, and many projects actually funded by your country. So thank you very much. Now we would like to take few questions because we're running short of time, maybe 3 to 5, and there will be only one round of questions. Anybody who would like to give a comment or question? Yes, there's a hand over there. So that will be number 1. Second, anybody would like? We are here, yes, number 2 there. 3. Okay. We'll be comfortable to have very few questions anyway because we are running short of time. So we start. Please, you introduce your name and where you are coming from, and you should be direct to the point.
Yeah, thank you. Thank you, the moderator, and thank you, the panelists. I'm Dr. Lipingo from Japaigo. I've got a member, also a MPD SALAAM Steering Committee member. The firm's name is Zoom. Now I've got 2 questions. One to the keynote speaker, Professor Poem. There are a lot of methods of estimation of MMR. Like we have mentioned, the survey, the census, the direct count, the unit estimate, the countdown. Now, what is the reliable method that you can say this is the best method to be used? The second one is to my friend, Dr. Makwane. I think congratulations, we have struggled a lot to make sure that we have reduced the maternal mortality and neonatal mortality. Congratulations. But in 2015, we used the same method of sisterhood method. But we say, probably is not the best method that I used, Ramos. Now, the same method of sisterhood is used for this Tanzania demographic survey. Are you satisfied with this methodology, or you are still using other methods to make sure that we use the best method, as we have said previously? Thank you.
Thank you, Dr. Lipingo. Okay, there's another hand here, the second one. This side. So you have to be direct to the point because we are running short of time.
My name is Halima Kasim from Pediatric Association. My question goes direct to the Minister of Health. Although we have a tremendous reduction of maternal mortality, and we have still high the perinatal mortality, but this, the outcome of perinatals is it reflects the care of maternal quality. So what are we going to do to reduce the perinatal mortality, as it seems also the maternal care is not still very well, as the outcome is not so impressive currently. Thank you.
Thank you, and I just saw 2 hands. Maybe this will be the last hand, actually. Yeah.
Sorry, my name is Moke Magoma from Injenda, Tanzania. And my question goes to my friend, Dr. Makwani. Some of the issues you mentioned, which may be contributing to the high level of maternal mortality, is provide attitude, if I quoted you right. What are we going to do to address this challenge?
Thank you very much. And so we need to get responses now from the panelists. Dr. Makwan, can you shortly respond, very briefly, 1 minute?
Quickly, I would like to answer the first question. What would be the best method to track maternal mortality? Just to say that Sister, as they coined it, soon after Safe Motherhood initiative was launched in 1987. And so as means to track our progress, in 1989, Graham came out with this sisterhood method, and you can access the paper from there. But the biggest limitation that as the maternal mortality goes down, then because of the sample size, you are likely that you can't get those numbers correctly, and you can miss. And you can say the community has no maternal death while there is some maternal death as well. So the best method that is recommended is use of CVRS systems, whereby you count birth and death. Unfortunately, we are falling into third category of countries whereby this system is not very, very functional as we expected. And we did a pilot here in Dar es Salaam to collect data. Yes, we got some data of death, but the clarity of data within the system was a question that needs to be addressed. The second method is an expensive one, whereby you take 100% of the health facilities and communities as representative, whereby you count deaths. That is following the death of women of reproductive age. It is very expensive because you are talking about the entire community. I would say using this and where the country is going, notwithstanding the situation we are, the method we have been using, it will be likely that one day it may come up with zero maternal death because of the population issues. Currently, the issue we have been using, for example, in 2015, it was one household representing 1,000 households. And you can see there, if one household was representing 1,000 households, that sampling technique, that's why you have very, very wide confidence interval, and therefore you cannot get subnational data. The other area is we can't get causes from the sisterhood method. It is extremely difficult because, again, the issue of this is a community data and the details are difficult to get. So we'll see how we move ahead with our scientists available to see the best way of approaching that area. The second question or the outcome of perinatal reflects the quality of maternal care. I agree with you 100%, and I don't want to repeat that rather than concretizing with what you said. And Dr. Magoma, it is true, there's a question of providers' education, and we have seen this being reflected in interns exams. We are being asked, do we really have that required education system to have a product that we need in clinical care, but also in midwifery and nursing care? Those are the critical questions we need to answer. Submit.
Thank you very much, Dr. Makwan, and I guess all the three questions were directed to Dr. Makwan. I just want to thank you very much for Thais, you are asking a question, I guess, correct? Yeah, that has been answered, correct. Okay, good. So would like to thank the panelists for a good discussion, but there are a few key points that we needed to take from this discussion. One is that the maternal mortality ratio is decreasing over time. We cannot neglect that achievement. It's a good achievement, but we need to invest more actually in order to accelerate the reduction of maternal death. We need also to invest on reduction of newborn neonatal mortality rate as well. So we still have something to do. And this is a take-home message. We need to join efforts, to join forces, and all the supports are available, including our partners as well. We appreciate to what you are doing to our country, to our people, and we would like to request and to extend our special thanks to you, but also request you to continue supporting our efforts. So thank you very much, and I think it was a good discussion, and we hope if you have more questions, then we can meet outside for more discussion. And thank you very much. So while they are getting out, we can just have a round clap of hands so that we appreciate what they have done. Thank you.
Okay, so another round of applause to the panelists and to the chair as well. Excellent. You know, you're going to agree with me that as much as you'd like to keep time, the sharing and the learning that is going on within these panels is incredible, and sometimes we have to be flexible to the extent we can, and find opportunities where we can compensate where we had maybe went over time. So we have been sitting here for hours, and I think it is time for us to stretch. I think that we have posters in the hallway, so I encourage people to take a short break, make phone calls, go to the washrooms, reply to your emails, watch posters outside there. We're gonna be back here at Satano Kamili. Let us come back here at 11 o'clock. Karibuni. Na kuna mtu amedondosha simu pale nje kwenye banda la kupigia picha. Someone left behind his or her phone outside. If you have seen such a phone, please submit it here. Wanaitafuta wajaipata. Please share, bring the phone and I will really connect it to the owner.
morning once again. Can I request everyone to get seated, please? Let us get back to our seats. I understand it's a bit time to network, catch up, and exchange some views based on the previous sessions, but now we have to proceed. We have to continue with our program. Number try.
Ndani ya kipindi cha miaka miwili, serikali ya awamu ya 6 inayoongozwa na Rais wa Jamhuri ya Muungano wa Tanzania, Mheshimiwa Dr. Samia Suluhu Hassan, imeendelea kupiga hatua madhubuti za kimkakati za maendeleo ya sekta ya afya kwa kuzingatia Dira ya Taifa ya Maendeleo, sera, mpango mkakati wa sekta ya afya, ilani ya uchaguzi ya chama tawala na matokeo ya tafiti za kisayansi kwa lengo la kuimarisha ubora wa huduma, fursa sawa za upatikanaji wa huduma bora za afya na hatimaye kufikia lengo la afya kwa wote. Uwekezaji katika miundombinu, vifaa tiba na vitendanishi, matumizi ya teknolojia, upatikanaji wa dawa, damu salama, mafunzo kwa wataalamu wa afya na huduma za kibingwa na bobezi, pamoja na elimu ya afya kwa umma ni kati ya hatua za msingi zinazochukuliwa na serikali yetu kupanua wigo na kuimarisha zaidi utoaji wa huduma za afya kwa jamii, kuanzia ngazi ya kituo cha afya, hospitali za rufaa za kanda mpaka taifa. Ni wazi kuwa serikali ya awamu ya 6 imejipanga kuendelea kupigana vita dhidi ya vifo vitokanavyo na uzazi na kuchukua hatua stahiki. Kwa upande wa miundombinu ya huduma za afya ya uzazi, mama na mtoto, serikali imekamilisha ujenzi wa hospitali ya mama na mtoto Meta iliyopo katika jiji la Mbeya. Imegharimu shilingi bilioni 13.2. Serikali imeendelea na ujenzi wa majengo ya huduma za mama na mtoto, yani maternity blocks, kwenye hospitali za rufaa za mikoa kama vile Seketure iliyoko mkoani Mwanza, Geita, Simiyu, Mawenzi, Njombe na Songwe, ambapo zimegharimu kiasi cha jumla ya shilingi bilioni 71.1. Serikali imekamilisha ujenzi wa awamu ya kwanza wa hospitali za rufaa ya Kanda Kusini Mtwara na hospitali za rufaa katika mikoa ya Katavi, Mara, Songwe, Shinyanga na Geita, ambapo hospitali hizo zimeanza kutoa huduma ndani ya kipindi cha miaka miwili. Hadi sasa jumla ya shilingi bilioni 51.4 zimetumika kufanya kazi hiyo. Aidha, katika kipindi hiki, serikali imeendelea kuboresha huduma za uzazi na kuweka miundombinu stahiki na vifaa tiba katika vituo vya afya ili kuviwezesha kutoa huduma za uzazi na dharura, ikiwemo upasuaji wa kumtoa mtoto tumboni, yani CMOC. Katika kuendelea kuimarisha huduma za watoto, jumla ya wodi 37 za watoto wanaohitaji uangalizi maalum, yani NICU, zimetengenezwa.
Ili jengo letu la NICU ni jipya, lina kama zaidi ya miezi 10. Tumehamia hapa Disemba mwaka jana mpaka kuwa functional mwaka huu mwezi Januari. Jengo letu limetusaidia katika mambo mengi. Tulikuwa tunapata watoto ambao wenye uhitaji wa huduma za uangalifu, lakini tulikuwa hatuna huduma zinazopatikana katika jengo la NICU.
Tumekuwa tukiwahudumia watoto tofauti tofauti ambao wana shida. Kwa mwezi wanaweza kufika 200 mpaka 250, na wengi wao wanakuwa na shida ya upumuaji, lakini wengine wanakuwa wanazaliwa na uzito chini ya kilo 1 au chini ya 2.5. Tunasema kwamba wanazaliwa kabla ya siku.
Vile vile tuliwapa mafunzo sasa wale watumishi namna gani ya kutumia vile
Kamera moja mkijaza kwenye nani presentation. Kidogo sauti isikike.
in child mortality, which I will now show. You will see that for quite some time since 1992, child mortality, whether you are talking about under 5 mortality, you are talking about 1 to 4 mortality, neonatal mortality, it has already been shown, are all going down. And I would submit that one of the major reasons that you see this trend is because of the improvements in child nutrition. Because up to 45% of child mortality is contributed to by poor nutrition, by malnutrition. I think you have seen this slide many times. And you see that I have marked the area from 2015 to 2022 TDHS, where you see a very sharp decline in maternal mortality. I think in the previous session, there was a good discussion about what are the driving factors. And I think in the discussion, one of the driving factors that did not come up is the improvements in maternal nutrition. Because if you look at one of the major causes of maternal mortality is postpartum hemorrhage. And postpartum hemorrhage leads to death if the woman initially started with very low levels of hemoglobin. And I think these days you don't really see, very severe anemia. During our time when we were practicing, you'd see a woman coming into the labor ward with a hemoglobin of less than 3 grams per deciliter. And there were many of them, but now there has actually been a good progress. And anemia in women of reproductive age has actually declined from above the 40s. It is now around 28%. One thing that I need also to indicate here is that while there has been some improvement in maternal nutrition, the level of overweight and obesity has actually been increasing. When the Food and Nutrition Policy was launched in 1992, overweight and obesity in women of reproductive age was less than 5%. And the Demographic Health Survey of 2022 shows that it has actually gone up to 36%. And also, interestingly, it is also going up for men as well. About 17% of men are overweight and obese. I'm not sure whether you can see that very clearly. This is how Tanzania has progressed in terms of the global targets. There are only 3 global targets that Tanzania has achieved. One is the decline in wasting, and then the second is exclusive breastfeeding, the ones in green. And then the third one is, with the current maternal mortality, it has actually reached, the global target. The global target for countries like ours is around 140. And now we are 104. So this very rapid decline actually has made Tanzania reach the global target. The orange ones, these are where we have made progress, but the other ones which are red, it means we are off course. Now, just to conclude, a few recommendations. And I was thinking that as a matter of policy, we need actually to link nutrition with, you know, because when I looked at the conference title, it was RMCHA plus nutrition. It should really be part of it, not just a plus. I'm not sure whether I've explained myself there. And then see, I'm doing this because here it's, you know, it doesn't show very well. One thing that I would also recommend is that it would be important, I think, in all future conferences that nutrition becomes, you know, part of your deliberations. And looking at the importance of nutrition, unaweza kuifanya ikawa nani? You see, they called me the grandpa of nutrition, and as a grandpa, I cannot say. Yes. Sorry for that, because as a grandpa of nutrition, sometimes our eyes, you see, need some little bit of more support. So the third recommendation is that if you look at the importance of nutrition in human capital formation, and also not only in the formation of human capital, but is also actually an issue of national security, we need to ensure that supplies for nutrition are available, for example, in the MSD. I think in one of the discussions, there's somebody who mentioned we need the equipment to be available. We also need the supplies to be available for example, the premixes for fortification, potassium iodate, and also, you know, vitamin A and all that. The fourth one, I was talking to some of the nutrition officers, and you know, there is a suggestion that just as doctors and nurses get registered, it is important, I think, for nutrition officers to also be registered so that they have a board of registration, and then, you know, they can also provide the ethical and professional services that are required just as nurses and doctors. The fifth one is that there are lots of nutrition claims by quacks, by traditional doctors who claim a lot of things. You know, that they're selling this product or that product because it is good nutritionally. Those kind of concerns. One thing that you will notice, you must have already noticed, is that there is a very rapid nutrition transition that is taking place alongside the demographic transition and also the epidemiological transition in Tanzania. And when you, you see all these transitions, and Tanzania, we are in the process of you know, envisioning what we want to be as a country in 2050, and most likely we are going to be an upper middle income country by 2050, I think it will be very important for us to ensure that we continue and do better in the work we are doing. So, because, you know, the life of the next generation is actually in our hands. Let me end by saying that the 1992 Food and Nutrition Policy is now being evaluated, reviewed, and then most likely an updated one will be proclaimed. And the Minister of Health has requested me and a colleague who used to work in the Prime Minister's office, Mr. Obey, to do both the evaluation and then support the development of a new nutrition policy. We shall call it a nutrition policy, not a food and nutrition policy, because in nutrition, while food is extremely important, it is not sufficient. You also need care for children and women, and we also need, you know, the basic services to be available, basic services in health, in education, in water sanitation, and also in social protection. I think with that, let me end there, and thank you very much for allowing me to give some few words. Thank you.
Thank you, Professor Kavishe, for your well-detailed keynote information. I usually admire your knowledge, your really loaded, and your wisdom, as we call you a grandfather of nutrition. And when I grow up, I wish to be like you. Let's put our hands together more for Professor Kavishe, please. Now, I would like to call first for my panelists. I'll start with Dr. Leonard Katalambua. Dr. Leonard Katalambua is a lecturer at the University of Dodoma. He's a head of Department of Public Health at the University of Dodoma, but also he holds a PhD in life science and bioengineering with 14 years of experience, and has been doing research and consultants in the area of integrated HIV, TB, malaria, and antenatal and postnatal care. And he's a member of Technical Working Group number 6, which deals with reproductive, maternal, and child health, and is a board chair of the Action Against Hunger. Please, Dr. Katalambua, welcome to the stage. My next panelist is Dr. Amani Idiste Kakula. He's a lecturer at the Muhimbili University of Health and Allied Sciences, and is at the Department of Ops and Gyn, and is interested with research on reproductive endocrinology, diabetes mellitus, and nutrition, but he's also a PhD candidate at the University of Antwerp, Belgium. Please welcome to the stage. The last but not least is my mother, Hilda Misano. She's the founder, member, and executive director of Nutrition, Health, and Development Center, NUDEC. And this is an NGO addressing food and nutrition-related national development. And she holds a Bachelor of Science degree in food and nutrition. And she has experience of dealing with food and nutrition for over 45 years. And she is expert in designing, implementation, reviewing of policy, evaluation, and training program. She's a member of the Technical Working Group of Nutrition Service Deliver and the board of Tanzania Non-Communicable Disease, and also a board director of East African Non-Communicable Disease Alliance. Please, Hilda Misano, welcome to the stage. And last is my sister, Juliet Itatilo. She works with TFNC at Nutrition Policy and Planning Department. She's hold a master's in nutrition degree in human nutrition from Ghent University, but also she provides technical support in various platforms such as National Macronutrition Action Plan, but also serve as technical capacity and advocate on nutrition-sensitive intervention. Please, Juliet, you're welcome on the floor. Let's put our hand together again to the panelists. And thank you, the organizer, for being gender sensitive. I think this first panelist, which is balanced with gender, but also I can see there's a wide range of age, from the old Mama to Idris and Juliet. Thank you a lot. As we all are aware that this session is focused on the nutrition service as the key to RMNSHA outcome. So we'll be focusing on looking at what are the nutrition issues which are the potential outcome to reproductive, maternal, and child health. So our first question goes to Dr. Katalambua, and please kindly be brief because you're out of time. We are trying to balance time. What is your current, know on the current situation on nutrition supports when it comes to pregnant women, lactation, mothers, and their babies? Can you please brief on the current situation to regard to this area? Karibu.
Thank you so much, moderator, and also thank you so much, members of the conference. I will present my comment in Swahili. I know we are all conversant in Swahili. And generally, we are going to see how the situation is with regard to nutrition in relation to reproductive, maternal, and the child health. Kama tunakumbuka jana wakati mgeni rasmi anafungua conference yetu, alizungumzia swala la siku 1000. Siku 1000 zimetumika kama dirisha la kuangalia hali ya lishe ya mama pamoja na mtoto. Lakini ukienda kwa ndani ni zaidi ya siku 1000. Tunatarajia kabla mama ya kushika ujauzito atakuwa ameshaanza kujiandaa kwa ajili ya kushika ujauzito. Lakini siku 1000 zimeangalia tangu aliposhika ujauzito mpaka mtoto anapofikisha miaka 2. Sasa mara nyingi katika masuala haya ya lishe yamegawanywa katika maeneo makubwa matatu, hasa katika eneo la mama na mtoto. Yamegawanywa katika kipindi cha ujauzito na kujifungua kwa mama mwenyewe, lakini yamegawanywa katika kipindi cha siku 0 mpaka siku 28, na pia yamegawanywa katika mwezi 0 mpaka miezi 59 ambao ni miaka 5. Na hata takwimu ambazo zimewasilishwa katika vifo vya kina mama, takwimu ambazo zimewasilishwa katika vifo vya watoto wadogo na wachanga, katika takwimu za vifo vya watoto wa chini ya miaka 5, ukiangalia zimebase katika maeneo hayo. Tukianza na mama mjamzito. Mama mjamzito yuko kwenye hatari kubwa kadhaa. Moja ni kifo kwa mama mwenyewe. Lakini cha pili ni kujifungua mtoto ambaye ana uzito pungufu, au kujifungua mtoto chini ya umri wa mimba, au kupoteza mtoto kabisa, stillbirth. Hayo ni baadhi ya mambo ambayo mama yanaweza yakamkuta katika kipindi cha ujauzito. Lakini kwa watoto chini ya siku 28 wako kwenye hatari ya kifo au magonjwa. Watoto chini ya miaka 5 wao wako kwenye hatari ya kifo au ukuaji hafifu. Ukiyachunguza yote haya kwa sehemu kubwa yanachangiwa na lishe duni. Lishe duni ya mama inahatarisha maisha ya mama. miezi 59 wale wa chini ya miaka 5, udumavu umezungumzwa, lakini sehemu kubwa ya hawa watoto ni katika kipindi kile cha miaka miwili inapofika wakati wa ulishaji wa vyakula vya ziada baada ya exclusive breastfeeding. Tumeona exclusive breastfeeding imepanda, lakini bado ni changamoto. Pia intervention za unyonyeshaji baada ya kujifungua katika masaa 24 ya kwanza pia na yenyewe bado ni changamoto kidogo. Sasa nizungumze kidogo hata halisi ambavyo ipo. Kuna msisitizo mkubwa wa masuala ya lishe, lakini uwekezaji kwenye eneo la lishe especially katika human resource bado competence pamoja na uzalishaji wa wataalamu wa lishe bado ni mdogo. Niombe serikali na wizara wawekeze sawasawa kama ambavyo wanawekeza kwenye maeneo ya profession nyingine, na eneo la lishe liwekezwe sawasawa. Keynote speaker amezungumza swala la accreditation pamoja na licensing, swala la kusimamia maadili, isionekane ni kazi ya mtu fulani. Tuendelee kuwekeza kwenye eneo hilo. Nashukuru sana.
Thank you, Dr. Katambua, for your nice presentation and comment on the status. But I'll wish to come back to you later. If you have numbers as regard to the current situation of the pregnant women, lactation, and the mothers and their babies, when it comes to statistics of nutrition, I would appreciate if to get that information. Now, based on what you have said so far, I would want to give a stage to Juliet. I know you are from a research institution and you do a lot of research and program. Perhaps you could recommend what are the recommendations that the policy gaps you would say you wish to see to be in place to improve nutrition support to pregnant women, lactation mother and their babies. Please be brief, we are out of time.
Thank you, Chairperson. As Dr. Katambula has already mentioned a lot in terms of the challenges that in maternal nutrition and also in terms of the services that are available. So basically, much is already being done, and we, as Dr. Katambula has already mentioned, that there are evidence-based interventions that are needed to actually ensure that we have health pregnancy and positive pregnancy outcomes. To mention nutrition counseling, nutrition assessment during pregnancy, supplementation, all these interventions are already in place. So now what we need to do is to actually intensify and improve the quality of these interventions that are provided to pregnant women or maternal in general. And my recommendation will be in two ways. First, we need to try to reach to the woman before they actually come to the facility. So we need to invest on behavioral change interventions. We need to actually create demand for nutrition services from a woman perspective. So some of my recommendation will be to start looking at the way that we reach women before they are pregnant. That way we'll be able to address some of the early challenges that women encountered, because most of the time we wait until they are pregnant, and some they attend and see when it's already late. So let's start at the community and let's start to try to invest on behavioral change intervention. I know we have already started with promotion of village health and nutrition days. Those are the initiatives to actually make sure that the community is aware of the nutrition issues and to try to create demand for these nutrition services. And it will also instill health-seeking behaviors among women. So they'll be the ones seeking for this nutrition support before they are even, before they are pregnant. They will know what they need to receive once they are pregnant. And As the community also, we need to see how we can engage and capacitate community health workers to support nutrition services at community level. And this also goes with a multi-sectoral approach. At community level, we need to engage more sectors beyond only health sectors to make sure that we capture women of reproductive age at different angles, not only when they are at health facilities. But in terms of health facilities, we need to improve the quality of services that are available. We know that nutrition, for instance, nutrition counseling is provided at facilities. But what kind of counseling are they receiving? The quality of the counseling. So we need to actually make sure that we have skilled human resource at the facility who can actually deliver nutrition services. So once we create demand, we are sure that they can go and get the services that are of good quality. And also to make sure that they we have commodities at facilities, for example, iron folic acid supplements, so that this demand creation goes hand in hand with the services that we are providing. So basically, we have already started to do, all these interventions are on place, but we need to make sure that they are of good quality, and we need to make sure they are accessible to all women. And also, we need to try to identify some of the key barriers to the access of these services, so that we can actually address specific barriers. We know Tanzania is a diverse country, and in terms of nutrition practices, there are a lot of different reasons, depending on the context, why they practice what they practice. So if we want to actually improve these services, we need also to work on specific barriers based on specific context and try to address those barriers. And to wrap up my point, I would just recommend that we ensure that key nutrition actions are delivered through primary health care effectively. It's supposed to be part and parcel of primary health care services. So to make sure that everybody is accessing this nutrition services at all times. Thank you.
Thank you, Juliet. That was very good. So our next on the panelist is Dr. Amani Kikula. I know you are practicing at Muhimbili Hospital. So you have a lot of clients, and you've been consulting the different places, and you're from Agota, also the association. So you know much on the implication of poor nutrition when it comes to reproductive, maternal, and child health. So can you please highlight based on your experience, what are the implications of poor nutrition? For 2 minutes, please. Be brief. Thank you.
Thank you, Mr. Chair. Since I've been given 2 minutes, as far as nutrition and reproductive health, a number of people have been talking about during pregnancy and stuff, but it starts from the time the baby was actually conceived. If it's a baby girl, it starts from that point. Since yesterday, we've been hearing the golden 1,000 days, which spans towards the 2 years point. And whatever the mother that has conceived is eating has a bearing to the cognitive status of this baby when it's born. Now, I'll move on towards, because I've been given 2 minutes, I'll move on towards the statistics that we all have. The stunting level for under 5s is around 30% now. And we all understand, since the question is on the impact of nutrition towards reproductive and child health, with stunting, you have a number of adverse obstetrics complications. Before conceiving, issues on infertility, during conception, during pregnancy, issues of premature labor, and even during the point of delivery, obstructed labors, and so forth. Now we move on towards, this is the time when a child has to be eating properly. By properly, I mean nutritious food. And there have been a lot of debate, what is nutritious, the quality, does it vary across regions, and, but this is not the point of that. But what I'm trying to say is, we move on from the 5-year point towards this group that has been, I would say, neglected, the adolescents. The adolescents are vulnerable in so many aspects as far as nutrition is concerned. There are social constraints of how they should appear, which will limit what they eat, how much they eat. And this has a bearing because this is the time when the body needs a lot of energy to build up the changes of the hormonal changes that are taking up. And if we move towards the girl, the adolescent girl, who's also starting to menstruate, she'll be losing a lot of iron. And if she's limiting herself towards what is to be eating, complications when she conceives, we have our numbers of adolescent pregnancy. So this is the time when she's supposed to be building up her body. I'm not saying that ladies are for only conception, but the likelihood is high. And if she conceives, she even deteriorates her health further. But now we have a double burden because I've moved on towards adolescent and pregnancy. We have a double burden. The prevalence of anemia in Tanzania is still high, over 50%. But also this hidden level of obesity and overweight, which is also a component of malnutrition. We have numbers that are climbing. In the general population for women of reproductive age, it's almost 25 now, 25%. And we all know the risks when you are overweight or obesity, just to mention a few: diabetes mellitus, hypertension, and all sorts of complications that are related to pregnancy and even sexual and reproductive health, because it affects even the time when you want to conceive. It affects your sexual life. It affects all sorts of reproductive aspects of life. And just to wrap up, the chairs insisted on the time. We are talking of nutrition and reproductive health. This cuts across because reproductive health not only limits towards during conception or as when someone wants to get pregnant or during the time of pregnancy, but it also have a bearing particularly for the women in the menopause state, because the hormonal changes, the calcium levels, and the risks that a woman would have osteoporosis, bone mineral resorption, has a bearing on what the woman has been eating before so as to cope with the menopause state. As a final note, as we are all aware that there are a lot of diets that are going around, do they really fit our context as far as reproductive health is concerned? If we are to eat only greens in a population where anemia is prevalent, and we all know that iron content is higher in red meat, do we really have in our setup have to eat greens as how is portrayed in a population where they have fortified their foods, they take supplements on a daily basis? Are we also doing that? Do we really have to eat that? That being said, we are so far compromising our sexual, reproductive, and adolescent health as far as nutrition is concerned. I hope I've answered your question, Mr. Chair. Thank you.
Thank you. Thank you very much, Amani. That was good. But I'm still confused. There's a lot of issue. You said people, they need to come early, the pregnant women, to get the service. They need to eat well. But there's this also theoretical. They say that you need to prepare before you're conceived. And most of our girls and adolescents, they just know 3 months later that they're pregnant. And less than 60% are attending the full visit. So where will this nutrition intervention, quote unquote, help us to solve? So that's something we thought about it, and maybe we'll come back to you later. And the last one is the senior, Hilda Misano, bearing on mind what they have said from Dr. Katalambua, Juliet, and Amani. So we need to hear now your wisdom. What should be done at the policy, health facility, and the community setting to improve the nutrition good outcome to pregnant mother children and adolescents as well. Karibu.
Thank you, Chairperson, and thank you, organizers, for including me in this conference. I agree the keynote address and the colleagues here have addressed most of the nutrition issues, and I'm just supposed to link those with policies, facility and community services. But before going there, I just want to point one thing on nutrition. As we all know, malnutrition is an outcome of processes in the community. It's not just a health factor, a food factor, a caring factor. It's a business, I think, of everybody. So when we are dealing with malnutrition, we have to have that at the back of our minds. As far as reproductive health is concerned, I'll stick with stunting. And here I would like to say that once stunted, you are forever stunted, unfortunately. And this goes along with the southern days that would want to intervene maximally to reduce that burden of being forever stunted. The colleagues have discussed of early booking, I agree. They have discussed of the supplementation at health facility level. It's very important. And he has touched on adolescents. That one is also key for successful reproductive outcomes. In a way, if you want to address nutrition, you have to look at the life cycle. But let's get back to where we would want to belong. Lack of these facilities during pregnancy, and at this time I would wish we could have iodated salt in every household. As we say, mothers are coming at 3 months for booking. But iodine deficiency at that level would compromise brain development, which has a lot of consequences in human development and national development. So my wish is, if we could have iodated salt at all households, would be a better beginning for the lives of these people. I wouldn't touch on supplementation and pregnancy monitoring at health facility level, but I would like to add to that, in order for the women to be able to gain enough, at least it's recommended they should gain about 10 kilograms during pregnancy, assuming that they were not obese to start with, and also be allowed to have rest during pregnancy, especially the last quarter, so that the growth of the child in the stomach will be, I wouldn't use medical terms, would be good enough to avoid low birth weights. So increased intakes plus rest is crucial to ensure that we don't have the problem of low birth weights, which is a bad start. After delivery, in terms of nutrition, and that's where there's a policy implication, that child to benefit from the breast, they have to be fed, introduced to the breast within 1 hour after delivery. If we could do that, they will benefit from the colostrum and all the benefits of the colostrum, and have to be exclusively breastfed up to 6 months, which we are glad the numbers are rising, but we would want to do better so that we don't miss anyone out. The problem and major problem in our country starts at complementation. After 6 months, when we start to introduce the solids, hapo ndio kunapata shika. We don't have good practices. Children are not complemented as expected. Some are complemented earlier, some are complemented later, which leads to colossal levels of stunting up to 2 years. And as I said earlier, brain development takes place in the first 1,000 days of birth, from gestation up to the 2 years. If cognitive development, the intellectual development did not have the right mix at that time, then that person has missed the train. You can improve on linear growth after the 2 years, but mental growth will not be improved. So we are losing a lot of human resource in terms of benefiting from the intellectual development. So I would outline that and then look at the policy implications, which are very easy at this point. First, I would like to bring to your attention that we have a mother law, which was enacted in 1973, but by our founding father, Mwalimu Nyerere. He was very passionate with nutrition. So there is a law which is known as the Food and Nutrition Act. This is the one which led to the establishment of the Tanzania Food and Nutrition Center and to the active participation of people in nutrition work in this country. I think that he had a very big vision that without proper nutrition we cannot develop. Unfortunately, almost 50 years later, we have 30% stunting, so we have to think of how we can make that better. As the keynote presenter has said, we have a 1992 food policy, food and nutrition policy. To me, the food and nutrition policy is supposed to lead other sectors in nutrition actions, what they can do. As I said, it's a multi-sectorial thing. Each sector has a place to take and to intervene to improve the nutrition of this country. So I'd call upon the Ministry of Health, I know they're working on it, so that they can hasten the outcome of that policy so that we can have at least a lead guide. The community development, the financing, the other actors will be able to engage more actively with the lead of that policy. Here I would like to caution, when we talk of food and nutrition policy, we are not thinking of agriculture. As we all know, the outcome of nutrition is basically food. So food should be seen as one of the tools, actually the very starting tools to ensure good nutrition. It could be from the agriculture sector, which could be crop, which could be livestock, fisheries, game, and whatever we call food in our communities. So I hope finally we'll get a food and nutrition policy from this process. Having said that, I would like to say at facility level, the early bookings have been mentioned. Let me touch a little bit at community level before we close up. Of course, the human resource at both levels is crucial, and I think at community level it's even worse. We have many actors, and they're doing their work well. Community development field workers, agriculture extensionists, they have a nutrition component. But I go as an agriculture extensionist, and then I teach crop, and then I say, you know, which are useful for nutrition. I walk out. Someone else will come with something else. Community development will come with caring practices, maybe, and feeding practices. I would wish, if it's possible, to have someone at that level who could help coordinate all these efforts so that we have good outcomes. I'm happy that Honorable Minister for Health said yesterday that they are starting a community health worker.
Mama Misana, if you could round up, please.
Yes, I'm rounding up.
Thank you.
So I think that will be one way of getting into her services. What I would like to stress at community level, let me point out that food is a very social issue. What is food to you might be poison to me, according to my background. So when we get to the communities, let's try to also listen to what they have to say. They have some knowledge, we can learn, and maybe mix up to be able to come up with better practices that will help all of us. I submit.
Thank you, thank you. Let's again put a round of applause to our panelists, please. I appreciate your contribution and your wisdom on nutrition intervention. So when we are about to round up, if you have a question, please, I'll take a few questions on one or two. I see there are a few hands. Okay, the microphone. I will start from that side, and we'll finish up. Please be brief. Be brief. Just introduce your name and where you're working, and then ask your question.
Yeah, thank you very much. My name is Elizabeth Proskovia. I'm working with World Vision Tanzania. I appreciate all the presenters, and my question will go directly to the policy gap that Juliet has identified. Well, from Dr. Kavish's presentation, we saw we didn't have a food and nutrition policy from 1992 to date. It has not been reviewed, but we have seen significant improvement in child nutrition status. So as we are reviewing to get the new policy, what should we expect and what this new policy will bring in that we have not seen for the past 20 years without the policy? Thank you.
So Juliet, prepare the answer, and you have only seconds to respond that. Karibu.
Thank you, panelists. I'm Ola Jahanpur from THPS. I would like to know, as we are reviewing the policy, is it time now to allow a breastfeeding mother to stay at home for 6 months instead of 3, to be able to do exclusive breastfeeding, and those in informal sectors to be supported to be able to stay with their infants? Thank you.
Thank you. And the last question over there.
Thank you, Mr. Moderator, a wonderful panel. I'm Musa Mohammed, I work for DSW. So to the panelists, I'm interested to know what are the legislative framework that we have within the existing health policy as a guide to investment on community health strategy, so that we can harness the existence of community health promoters within the community to create awareness on nutrition and also the issues of delayed first and second clinic. Thank you.
And this question you're asking to among the panelists?
Amani and my mother are there.
Okay. So can we respond, please? Just a few seconds. The time is out. Juliet, kindly be brief.
With regard to food and nutrition policy, I know the grandfather is here who actually is working on it, so will complement my points if need be. So the policy has been here since 1992. So to know what is new, that's why we are having evaluation at the moment. So we are starting with evaluation to see what is missing in the policy. Of course, I mean, it has to be multi-sectoral policy. So we are trying to look beyond things that we are doing in, on the nutrition side. Since 1992, our policy has been multi-sectoral, of course, if you have seen it. But now we are looking at further to see, with this transition in nutrition, what is missing? We have issues around transition, fatty acid. There are so many other things that are keep on coming up. So I think it's good for us to evaluate and see what is missing so that we can actually improve based on our current status as far as nutrition is concerned. And that the same will apply to, seeing the need to actually have maternity leave for 6 months. So based on the evaluation and the evidence that we have, will that work for Tanzania? What can we do? That will be part of the discussion as we are evaluating the policy and recommending for new, updated policy. So I think we have not delayed. It's on the process, and our facilitator or consultant is here. So I think those are the issues that can actually be accommodated and see, we can have further discussion on what can be accommodated in our new policy based on what we've seen in the evaluation and new evidences that are coming up. Thank you.
And the other question about from 6 months from 3 to 6 months, because we are preaching here exclusive breastfeeding, but women, they come back to work after 3 months. So how would they manage exclusive breastfeeding? So is this part of the policy change, yes or no? Just say yes or no.
It's not a yes or no question, but I think now we can open the discussion for that. Like, can we have 6 months? Would that work for Tanzanians? Would mothers themselves as well, how would they, what would they say about staying home for 6 months? Of course, I wish we do that. I know the hassle.
So, Professor Kavishe, would you consider in your consultation work on the change of, you don't need to answer that now. So the person who answered the question, asked the question, maybe you're close to Professor Kavishe, he's the one who preparing the next nutrition policy. So the last question, my friend, as the minister discussed yesterday about their revised program on community health workers, I think they will take in consideration the registration guideline on what you have proposed, because you are running out of time. So I want to take this opportunity to thank you, the keynote speaker, Professor Kavishe, and my panelists, and of course the organizer and the audience for your active listening and asking questions. There are a few take-home points from this presentation. Besides the challenges that we have been discussing here, but we really have made big progress. We can just clap for ourselves. So the progress, the first progress I would say, which surpassed the international targets, is the 64 exclusive breastfeeding. So when you change from 3 to 6, I hope it will be 100, I assume. If now we are 64, and I hope these are true statistics, quote unquote. And the other one, which is still shocking, is the maternal mortality rate decrease. This is significant, and we have surpassed the global targets. And wasting, which is less than 5% prevalence as a global target. So we are doing well, besides all the challenge which we have. So I want to pose the last thought, maybe when you are going out, keep on thinking. We have heard a lot about stunting, and that is when you do anthropometric measure, is when you do the height against your age and see if you've grown up very well. But I'm a bit concerned about mental stunting. So I pose the question, I know there are technical minds here, how will you measure in the next maybe conference? We can come with a technology, how would you measure mental stunting? Because this is a really big problem. We have said the first panelists about training, say the competence-based training, they are more worse than the other non-competence-based training. Maybe there's a mental stunting somewhere. So we need a technology to measure the mental stunting. Thanks a lot. Thank you, Bishanga. The floor is yours now.
Another round of applause to the panel. Asante sana. I think we can't overemphasize on the importance of nutrition, not only in health, but in all other parameters, the social parameters of life, including education itself. So I think, yeah, we need to do more. I don't want to start another discussion here as a keynote speaker. So now we are heading into our breakout sessions. I realized yesterday that not everyone could access the program and be able to identify where the sessions are running. So I want to take you through the location and the topics that are going to be discussed for the next 1 hour. And please, moderators, take note of where you're supposed to be. And you will be responsible for managing the time. The sessions will be for 1 hour. After 1 hour, one of the organizing team member will come and ask you to release the participants for them to come for the next session. So you will end up where you'll have reached by then. So under Mikumi Hall, we will have a topic on RMNSH commodities security. And the moderator there is Dr. Phineas Sosipita. So if you're interested in that session, please go to Dr. Phineas Sosipita, Mikumi Hall. Sadani Hall, we have a topic on tracking maternal and perinatal mortality in Dar es Salaam and urban settings. And this would be chaired by Mama Fedi Mwanga. Please take note of the venue. Afya will have a topic on community healthcare workers and engagement, and Mr. Johnny Fully will be chairing the session. So please make sure you go to the right session. And for Uduzungwa, the topic will be family planning service delivery to special groups, and Dr. Anna Temba will be chairing the session. The session that was formerly planned to happen under Gombe, it has been moved to Amboni. All the sessions that were originally supposed to take place at Gombe, they will now be taking place at the Amboni Hall. And this is, for this time, it is cervical and the breast cancer screening being moderated by Dr. Gloria Shirima. So please take note of the venue. We will, and all the speakers, if you know your abstract was assigned to one of those sessions, make sure you make it in time. So we are going to break now, and after 1 hour of the breakout session, you will, please moderators, release people to go for the poster session. Tutakuwa na break ya kuangalia posters pale kwa dakika chache, alafu tutapata chakula. Kwa hiyo kutokea sasa tutarudi hapa tena saa 8 na dakika 10. Ila kuanzia sasa mpaka saa 7 na dakika 20 tutakuwa tunatakiwa tu tunamaliza hizo breakout sessions. Then tuna break for lunch na poster viewing. Saa 8 na dakika 10 tunarudi hapa for another plenary. Ushers and conference organizers, please help us to remind the moderators and the guide people to come. Hakutakuwa na chakula kabla ya session ya breakout haijaisha. Naomba tufuate hiyo. Asanteni sana, nawatakia sessions njema, na see you here after a few hours. Sorry, an announcement. Kule kwenye breakout sessions tutagawiwa kuponi za chakula. So make sure when you are going into the room, you'll be scanned your badge and get a coupon for meals. So please make sure you get your coupon before it turns 1 p.m. Kuponi za chakula, ushers, naomba mwende kwenye hivyo vyumba mkagawe kuponi za chakula.
shooting behind me. Oh. Eh? Si wale kule. Si wale kule. Iko wapi? Yani, I will not be able. Huo ndio ukweli. Mkeni na mimi. You did it? It's showing. There you go. Wow. Does it show?